Going live.
Now live.
Hangout is on the air. Isn't that wonderful? Technology is great when it works.
When it works.
And sometimes it doesn't work as well as we would like. So we are rebooting and creating this webinar again. So thank you for watching it in the replay, and our apologies to anybody that was inconvenienced this morning. Hi, this is Sam Small. Welcome to our webinar for MMT6 documentation. With us today are Juanita Thompson and David Marin, and I'm going to simply turn things over to David, and we'll get started.
Thank you, Sam. Glad everyone is here, and welcome to the webinar on MMT6. I did want to say thank you for making time to check in with this and add this to your whole repertoire of information. We appreciate it very much. This is yet another aspect of the whole program, and we're glad that you're getting things out of it. I do want to say a few words about the live classes. I've returned from one trip to meet with a group in Las Vegas as well as Dallas, and I want to tell you that we had two fine sessions with some outstanding therapists who were eager to learn more about the hands-on work, and we found time to cover the assessments as well and iron out all manner of questions and details about how to apply the work. And I want to say some things about that a little later on, and Juanita is going to run the show primarily today with respect to MMT6 because, frankly, it is her course. She created this course for the program, brought it to the program, and is most competently adapted and able to conduct the class much better than I. So that's why she's doing it, and I'm going to be second fiddle here and add in what I can when I can. I did want to say that if you are preparing to go to the online class, the on-site class, pardon me, then we urge you to certainly complete as many of the tests as you can and practice the techniques in your practice with your clients and be familiar with them. The more familiar you are with them when you come to class, the better off you will be, and the more you'll get out of the class. At that class, I'll be demonstrating and showing you treatments, and you'll be actually working on each other, the other students, and giving and receiving treatment for the entire body. So we'll have an intensive marathon, if you will, for 4 days of body work. So it is quite illuminating and quite invigorating, I found, with the other students to come to that, and I look forward to your presentation or your presence at such a course as well. So with that said, we appreciate everything you're doing in this course. Stay active with the chat, with your questions, and with learning more about this program, and we certainly are thankful for your participation in it, and we will do anything we can to make it a more rewarding experience. Juanita and I check the chat, and Sam does too, daily, to see what we can do to answer your questions and give you more knowledge, more encouragement, and more connection to the program. So with that, I'll turn it over to Juanita and let her start the dissection, if you will, or the discussion about documentation of our work, how very important it is in this field of clinical massage therapy. Juanita.
Well, David, even though you might be second fiddle, you still make good music.
Oh, very nice. Thank you.
You're welcome. You're welcome. So, folks, since this is not a live webinar, we just wanted to remind you, and David had mentioned the chat, but if you do have questions as you watch this webinar, please post them on the chat, and either David or I will be glad to answer them. And again, we apologize for the technical problems, just sort of out of our hands. Okay. So today we're going to be talking about documentation. We're going to be looking at some forms, the SOAP note forms, the history forms, and I have a discussion regarding that a little bit more than what's in the manual itself. But first, before we begin to look at those forms, I do want to talk a little bit about the general purpose and benefits of documentation. This is a recap, but I firmly believe in repetition. Repetition is the key to learning, and as we talk about everything today, there's a major focus that we want to share with you that deals with how to learn, how to take a body of information that might take a while to sink in, and what the best process is to be able to learn that. Repetition is right at the top of the list, and so even though I may be repeating some things that I said before in the last number 6 video, it's important to repeat it so that everybody can hear it again. I'll be looking at page 2 in your manual. If you have your manual handy, you might just open up to page 2, and this is the purpose and benefits of documentation, and I have 5 bullets there that I'm just going to briefly go through again. The first reason has to do with being able to gather information so that we can determine the indications for massage therapy for your client. We want to know where we're going to be working and what we're going to be doing, and also to be able to determine the contraindications, which are totally based on your client's history and their general health and age and what it is they're looking for. So that's the first thing, indications and contraindications, 2 important words. The next one has to do with developing the therapeutic relationship. Communication is a big key and a big must in establishing rapport with your client prior to the massage therapy. We gain information through the history, but we also, as we're going to be looking at today, we also want to be able to ask questions and have a conversation about their history so we can add to the important information that maybe they did not share. And it's often common that people are so anxious to get to the therapy that they don't put everything on the history, and they don't realize how important the history is. So being able to converse with them becomes very important so we can ask questions and stimulate their thought process in understanding that we need to know certain facts. The third one has to do with being able to have a record of what we're doing. In the clinical field, we would not ever think about doing a procedure of any kind without having it documented. So having a record is very important. The other reason, other than just having the record, is that the importance of being continuous with client care is one of the aspects that we encourage you to focus on. Clients don't want to think that you forgot what you did. And over a couple of weeks and seeing many clients, and a client comes in, and if you don't have any records, they might say something like, oh, I want you to do just what you did the last time because that worked great. I was out of pain for a week. And if you don't have any records, you don't know what you found, what you did, and you might not even remember what was wrong with them. So having a record is as much for our well-being to be able to provide good care as it is for the client itself. Another reason has to do with our professional liability insurance. Most of us have professional liability insurance, and it is somewhere in the small print that if you don't have a record with notes of your client session, that includes history and SOAP notes, then and there's a problem in this situation that your session will not be covered by the insurance policy. So insurance policies themselves, these liability insurance policies, require that we document. Some people will ask, is it usually state law that we document? And most of the time it is not. Documentation is not in state laws for any requirements, and so massage therapists think because it's not there that, oh, we don't need to do it. And while I didn't learn that in school anyway, or they touched on it, but we never practice it, so I really don't feel comfortable doing it. And these are all the reasons why people don't do this. However, I'm going to say all massage therapy textbooks that are current now with the standards of practice include at a chapter usually on documentation and SOAP note charting. This is something that becomes a standard itself. It may not be in state laws, it may not be even in your association standards, but if it's in the textbooks, and a lawyer could easily make a very good argument that you're not following the basic standards of professional massage therapy if you don't keep your records. And then the last one has to do with communication with other health professionals. And good documentation, objective documentation, which is measurable, is the way that we would communicate with physicians or chiropractors or physical therapists that may refer to us or that we are networking with at the time. And this is no small thing. I have to say that whenever I've had a client ask if it would be all right if they had a copy of their records because they wanted to show their physical therapist or to their physician, I was always very glad to do that for them. Because I knew that the individual who was seeing this, the other professional, probably had not seen massage therapists ever chart before. And true enough, I would get the feedback that they were impressed that I documented as much as I did, and that I did assessment tests, and my critical thinking was very good, and I even commented on self-care. So this in and of itself is a way for us to help our profession to have a better self-image, and it's one step at a time. And every time we make a connection like that through documentation with another professional, we're not only helping our own practice, but we're helping the practice of massage therapy itself.
The word that comes to mind for me, Juanita, is credibility. In doing documentation for all the reasons that you just went through, we get credibility with the client. We gain credibility with the client as we're asking these things, because very few massage therapists ever do anything like that before delivering a massage therapy treatment. And secondly, I've heard you say this before, I do believe, and that is, clinically and legally speaking, if it's not in the chart or in the file, it didn't happen.
That's right.
So that is the clinical rule, folks. So listen up, please, to what Juanita's going through. This is tried and true information from her years of experience as a nurse, as a massage therapy instructor and owner of a school, and having trained people for 20 years and more. This is important information, and we need to know this. This is what's going to separate us from the pack. Right. From the other massage therapists. This is going to be one of the primary things that separates us from the pack of people that are just, where does it hurt, and point to it, and that's where I'm going to rub. Or even doing good work without documenting. It's very, very important. Thank you.
Yes. All right. So I'm going to go on to page 3, and we haven't covered this information yet. And even though it's in the manual, one thing that I have learned from teaching is that not everyone reads well and doesn't learn well from reading. So I wanted to bring it out verbally and discuss a few of these items a little bit more extensively, and please comment or ask any questions on the chat. So this is on page 3, Basic Documentation Guidelines. So the first thing that I want you to understand is that our charts that we keep for our clientele belong to us. They're our property. However, because of federal right to access laws, a client could have access to their own chart. They generally, most people would like to have a written request to have certain materials copied for them. The standard is that the provider can usually take up to 30 days in order to get that to them, although there's, hopefully you won't be so busy that you can't get it to somebody within a few days to a week. Most people just want to have a record of what you're doing, but a lot of people want to share the information with another healthcare provider. If this is the case, then you need to have your client sign a release of information, written permission to do that, and even if you're just getting it to them, it's nice for you to know where this information is going, what physician or what professional this is going to. Fees can be assessed if it's not being used for a referral purpose. It just depends on how many pages, I guess, and whether you have a copy machine and that kind of thing. But the chart is to remain in your possession. Original copies of the client chart are always kept by us. We don't ever give away the original copy of a client's chart. Now, there is an exception to this rule regarding massage therapists and keeping their own charts from their clientele, and that is when you're an independent contractor for a business like a spa or you know, a massage place that you are not owning. Certainly, you would be making the notes and writing all the information and assessment on someone, and you would keep it. But standards say that if you leave that location, that the chart actually belongs to the business itself. And this can be very confusing, and I always suggest that if you are going to be an independent contractor with another business, that you iron this type of information out early on in the contract. And what most massage therapists will say is that upon leaving, that they want to be able to obtain copies of your client folders. I've only heard of one spa that would not allow that, and because they had one of these legal I guess it was contractual, that they do not work, that if the therapist were to leave, that they were not to work on any of their clientele, and they felt that by giving you the chart, that was why they didn't want to give the chart to the individual, to the massage therapist, so they refused to do that. What the massage therapist did was that she contacted all of her clientele with a note, and also sent the note to the spa saying that for legal purposes it was very important that she have a copy of the client chart, and if they would be so kind to ask the spa to make a copy for them. And about half of the people that she contacted said that was fine, and then the spa pretty much had to comply with the clients. So that's one of the only problems that you might have if you're working as an independent contractor. One of the reasons why you would want your chart, even if you're not seeing that person again, is that you never know what's going to happen in the years to come. Basically, charts are kept for a period of about 6 years after the last time you've seen someone, and there's a reason for that. There's I know of probably 3 or 4 instances where massage therapists were contacted later down the road because there was an accident, there was a lawsuit, lawyers were trying to get past soap notes to show that this individual was never complaining of neck pain during that period of time. So there were different legal processes like this, and then usually they will pay for a copy of the chart if it's, you know, being used for a lawsuit or something like that. So that's a very important thing. And not only that, but you would always want to keep your client records just in case the client had a problem and was implicating you in some improper action. You would always want to have your notes on hand so that you could have your record to help you out. All right. Clients need to fill out the intake forms and sign the informed consent prior to the session, and then I have when they are fully dressed. David, I'm hearing lots of feedback from your microphone there. Thank
I'm
you.
sorry, I was trying to adjust it.
Okay, thank you. I appreciate it. So you want to get all of this information while they are fully dressed, and this is very important. It goes to boundaries. It also goes to when the client is fully empowered. Whenever they're filling out paperwork and signing an informed consent, you want them in their full individual power. As soon as people take their clothes off and part of their mind is someplace else, and they're not as empowered. It's the same reason why, as much as possible, we try to have clients sit in a chair, with a clipboard to fill out their information, and then when we go through the history and ask questions, we're sitting in a chair across from them, having good communication. I've actually seen and gone to a massage therapist where I wasn't asked any questions until I was undressed and covered, on a massage therapy table. And that is inappropriate, and it's not good ethics. So just to remember that. You want to have everything when the person, prior to the session, prior to them getting undressed. Okay, let's see here. For children under the age of 18 or for adults that are unable to fill out the form, parents or guardians need to fill out the informational sheet and at least sign the informed consent. I mean, there's times when a teenager can fill out information, but the parent has to review it and then sign it, as well as if the child signs it. And while I'm speaking about children, I just want to say something about working with children. We don't have too much information on this in textbooks about informed consent, but it's a very important thing from my point of view that when you're working on a child, that you want to have the parent in the treatment room or close by in order to be in conversation with the massage therapist, and also just as a protection for the client and for the massage therapist. And the reason I firmly believe this is just history of knowing many therapists that worked with various children and problems that came from not having the parent there. It's just not acceptable to have a parent drop a kid off that's 12 years old and have them go in a massage room. I had one of my instructors once tell me that, and we had a discussion on this, that with all of the information that's been out there over the last 20 years about teaching children how to be assertive with people, how many times have we told them not to let anybody touch them? Don't let a stranger touch you. And these are messages that we give to them very early on. And then if we're not supportive of them when they are being touched professionally by a stranger, it can get complex from a child's point of view. So please respect that and protect yourself and make sure that a parent is close by or in the treatment room. All right. Forms should be filled out in blue ink rather than in black, and this is a change, and the change has come because copy machines do such a good job now that sometimes you can't tell which is the original and which is not. So the blue ink on your notes will always let you know which is the original. All forms should be dated, have the client's name on it. It's also wise for the therapist to sign or initial each page showing that you've read it. If something is written in error, it should be crossed out with one line through it only, so the mistake can be easily seen. Documentation should not be erased, and whiteout should not be used. This is an old rule of documentation that is a clinical rule, and it still holds fast today. It is suggested that all spaces on forms be filled out. In other words, if you have lines that are empty, and when we look at some of our notes today, I left some of the lines empty and also showed you how we would mark lines through it to show that we were done with that particular note so that we couldn't come back and add something later. Terminology and abbreviations should be standard clinical vocabulary. I have to say that it's been very confusing. As I was developing this course for my massage therapy school, I had 4 different textbooks about documentation, and all of them had different abbreviations, and only one of them had abbreviations that were specific to massage therapy. And so I tried, and that was Diana Thompson's book, Hands Heal. So many of her documentations I adopted in my class and have used in this particular course as well, mainly because they didn't exist any other place. So just to let you know that, and some abbreviations are different from place to place. It's information is not totally standard on even what the words that we use for SOAP and what those words stand for. I've seen many different versions of what the SOA stand for. Even though the meanings are the same, it's just that the words are different. All right, so the last one is important for you to understand because our clients' charts should be kept up to date, and forms that are commonly found in our clients' charts are certainly all of their intake forms, any assessment forms that you utilize, the SOAP notes, and a phone call log. If your client is calling you about how they feel after a session, that should be noted below the SOAP notes or on a special phone call log. So, because most of the time we would be giving advice or telling them what to do, and so you would document that as well. That's part of the communication process. You want to make copies of any of their prescriptions that they come with from a physician or a chiropractor, any copies of letters, legends of abbreviations, and an assessment test that may not be commonly used. So that's the basic documentation guidelines. Most everything that I said was in this paper. I added a little bit. Is there anything that you wanted to add, David, to that? Okay, very good.
Thank you.
Okay, David, if you would please talk a little bit from your point of view about assessments. We've been discussing this the last couple of days, and your observations and both of our communications with people about learning assessments and whether they're going to use them or not going to be using them, and feeling somewhat discouraged. So I wanted to give us a chance just to talk about that.
Thank you. Can you hear me okay?
You bet.
Good. So what I'd like to say is that the assessment area is new to most massage therapists, and yes, we have a bit of trepidation there, that if we don't know something thoroughly, we're reticent to do it, and also if we're slow at doing it and we need to check our book or make sure that we are doing it properly, we are sometimes, or maybe quite often, reticent to do something where we'll seem inept in the eyes of our clients. So just a simple suggestion on the AROM, active range of motion. That's where we're going to start every single time with a new individual coming into us. We're going to ask them to do the normal motions of whatever that part is that they're coming in with, that they would like attention on. So that's what we're going to be doing, and we need to therefore learn those for ourselves so that we understand that the neck has 4 motions: flexion, extension, lateral rotation, lateral flexion, and rotation. We need to know those 4 motions, and we don't need to remember the numbers per se because they're on every single assessment chart. We can check the range, we can take the data from the person with the goniometer and compare that to the range, and then we'll know whether they're really deficient in mobility of the neck and which motion it is. Now, to get to that point where you feel comfortable doing that, it means that we need to practice. We are kinesthetic people. We are gifted with palpation skills, and we need to practice hands-on with those assessments so that we feel comfortable. If that means taking a family member and going through them every day for a week to see how they vary according to our changing way of doing the measurement with the goniometer, for instance, then that's what we need to do. We need to practice enough to where we feel like doing it in the presence and to our client. So once we're at that place, then we're able to proceed with active range of motion for any part in the body. The area of passive range of motion, as you've heard me say before, I trust, is I don't usually use passive range of motion always. It's not imperative that we take the joints through their range of motion in a passive manner. It is imperative in our approach to do the active range of motion, to see what the client can do. It teaches us so much about what they're bringing in, one side relative to the other, if it's an extremity, etc. So that's a way to get comfortable with it. We also would like to be aware of manual resistive tests, which we sometimes might use. That would be just a simple testing of the muscle in its mid-range, in its mid-range of movement. If we take the neck, then mid-range in a lateral rotation or a rotation move, we would stop and challenge that to see if the muscle is strong or weak or has pain in it. And yet that would give us even more information. So in a typical setting, in a typical experience with a client, what I can say of a general nature, and I'd want you to remember this, please. I'd want you to go over this enough times in your own listening to this several times so that you really get it. Let's say that a client walks in and says that they have problem moving and they have pain in their blank. It could be neck, foot, hip, trunk, arm, wrist, side, anywhere it is. Let's take the neck, just for instance, the neck. So we asked them to fill out a history. We asked them to mark on that form exactly where it hurts, where it goes, what's involved, and we get a good visual on the red pen on the intake form that gives us an idea of A, where it is, B, possibly how severe it is as well. And then we simply ask the person to stand in front of us and do the 4 motions of the neck. We might measure that with the goniometer. We might have just look at their neck in a beginning way and then measure with the goniometer next. In any way, we get the data on what they can do on those 4 motions of the neck. And let's say, for instance, that lateral flexion is extremely limited, particularly on the left side. Just for instance. Well, handy for you, we have created in each and every manual a list of muscles in the anatomical review that indicate exactly which muscles do which motion. So you can very quickly go to your manual. If you have it printed out as a separate sheet, that would be fine too. But you can go to your manual, page 3 or 4, I would imagine, in the number 1 manual, and you'll see under anatomical review, you'll see neck flexors and a list of them. Neck extensors, neck lateral rotator, lateral flexion, and rotators as well. So you would look at that list, and that becomes literally your treatment list to start with on this client. It's a good place to start. Yes, neck pain can have many causes, but we, being musculoskeletal specialists and myofascial specialists, we're going to start with where we know what we know the best, and what we know better than most other folks do in the clinical fields. We would actually begin to work on those particular rotators. We'd work those rotators. We'd use the different skills that we have. We'd use skin rolling. We'd use some muscle energy technique, perhaps. We'd use some palpation over there. We'd work the SCM. We'd do all the muscles that we know of that are on that list, do the fascial work, and be as complete as possible. We might heat it up first because we honor hydrotherapy. We might warm it up before we treat it. We might finish off with 5 minutes of ice or cold as we finish because it may be inflamed. It may be restricted, and we might want to help that just a little bit, also to give them a little bit of a schooling, if you will, on the use of hydrotherapy. So from that work, we not necessarily test again, although you could certainly test again after your treatment, couldn't you? But we complete the treatment with 5 minutes of ice. We mention to them that the initial exercises that they're going to be asked to do, not prescribed of course, but asked, recommended to do, are the simple motions of the neck. The same 4 motions that we use to test the neck's flexibility are exactly the same 4 moves that we ask them to start with, and we ask them to do, for instance, 3 times a day. Go through the range of motion for the neck, particularly the areas that bother them, 3 times a day, and book their appointment for hopefully about the 4th day, because they're in pain, in discomfort, and lack of flexibility. They want to get better fast. It's not a matter of saying, see you in a week or 2 when you feel like coming back. It's a matter that experience shows, clinical records, clinical research indicates that a treatment on the 3rd or 4th day after that initial treatment is the best time to return. So they come in after they're doing their exercises, they've used heat, they've used ice at your request, and they come in on the 4th day for that treatment. You ask them, is it better? And you ask them to do the test again. You measure again. And you might measure it vastly different, vastly better. If it's better, then I would repeat the treatment that you did before, because I would repeat the treatment that I did before, because it was pretty successful. If it was rather unsuccessful, they say, well, it tests out about the same and they're not feeling much better either, then I might think of what else might be involved. If, on the other hand, they come in and say, you know, it's quite a bit worse than it was, then that's a sign for referral. That's a sign to get a doctor's opinion, to ask them if they've spoken to their physician about this. And maybe they should have the benefit of a physician referral and a physician consult to evaluate and diagnose the condition so that you can adequately treat according to the doctor's guidelines. So that would be a nice way of proceeding with just about anything that comes in the door. That's the way I proceed. And as I say, it could be ankle, it could be knee, it could be any part of the body. But that certainly is a wonderful way to proceed, allowing the assessment to be the guide for our treatment. The active range of motion is a wonderful, wonderful guide. It's used in clinical settings from physical therapy, athletic training, orthopedic surgeons, physiatrists, offices as we speak. It's happening all over the world as we speak. So if you want to join that crowd that's doing clinical things, then you have to do what they do. And this is what they do. And this is why we're teaching it. And this is why we're encouraging you to do it, to wade right in, get in the water, and add assessment to your treatment program. It will enhance and will change your whole practice. So did I miss anything, Juanita, that I needed to say?
You know, I just want to add a few things sure. As you were talking about getting feedback from the client, assessment is a good avenue for us to be able to get good information from our clients who may not tell us whether they like the session or whether the session worked for them. If the assessments are there, it's sort of a go-between you and the client. And so you can explain to the client something like this. You can say, you know, every person is different and is going to respond differently. There's lots of ways to employ massage therapy when someone comes in with this particular problem, and so we're in process here. And I use the assessments in order to get the best information so that I can be concise and go to the areas that I think may be restricted or problematic. It's up to you to please tell me about the pressure, whether you want more or less. And it's also important, if you come back in 3 or 4 days, I want to know if you did your self-care. I also want to know how it worked, if you were out of pain, and please don't feel like you will hurt my feelings. I need to know this to make sure that we're doing the best therapy for you. I think that a lot of massage therapists are just so grateful to have this avenue, because many clients will not communicate with them. They'll say, oh, it was great, it was fine, but then they don't come back. And I think that clients are worried that they would hurt your feelings if they would say, I'd really like more pressure or take less pressure. Certainly not everybody. I mean, there's many assertive people out there. But it is something for you to consider and another reason for you to add that. David, the other thing I just wanted you to mention as we were talking about the learning process. And I know that massage therapy education is so different from school to school, and many schools don't focus on anatomy and physiology. I've just recently taught at a school that doesn't teach any pathology at all in their program, and very little kinesiology. And so when basic programs are like this, and perhaps there's a focus on energy work or intuitional healing, then and massage therapists have grown and are practicing this way. Would you comment on that, a little bit of what we talked about a few days ago about the differences between intuitional massage and working with a more structured type of educational processes and the need for that? Do you remember that conversation we had?
I certainly do.
Right. Okay.
So I would say that the intuition that we bring to the session is going to always be important. Don't think for a minute that because someone has learned the names of muscles and learned the names of assessments and has a clinical approach and seeks to test and measure and record and document does not mean at all that they're giving up on their intuition. In fact, the intuition comes into play after this little bit of technical, clinical information gathering. When the intuition comes in is when the hands touch the body, in my experience, and that sounds very simple to say and very simplistic to say, and yet in reality, can you hear me still?
I can hear you.
Okay. In reality, when we go to work on that list of muscles that we gained from looking on page 3 or 4 of the anatomical review of that particular manual, that is when our intuition comes to play. We do things like check the good side first, or we might touch both sides at the same time to gain a palpatory influence on our hands. We are masters of palpatory literacy. We have wonderful palpatory skills in our hands and therefore connected to our intuition. So by touching both sides first, I can really get a pretty good idea of how the good side is supposed to feel and how different the other side feels. That's very dramatic quite often and can be a real avenue for intuition to guide us. Maybe the other side is tight as well. Maybe you'll find that the side that is not bothering them at all is just as tight as the side that is. That is an intuitive aspect that we would want to work on both sides. So the intuition comes into play very soon as the hands touch the body, making our decisions on how much pressure to use, how fast we go, the speed, the rate that we use, the areas that we cover, and how we cover them. All of these things are dictated by our intuitive and palpatory skills. But we have a foundational knowledge in the technicalities of it, so we gain credibility. We gain an awareness. We gain a respect from the client as well as our peers and other and physicians in the field.
Right.
So there's a great value of our intuition, and we do use it. It's just not a matter of that simplistic statement that I've heard too many therapists say, frankly, too many. Say, well, I just put my hands on the body and let my hands be guided to where they need to go. That is not enough, in my experience. Not enough. People rely on that intuition, saying, well, I feel like my hands are intuitive. I tie into my spirit guides, or I say a prayer, and I ask to be guided by whomever or whatever deity that I choose to subscribe to. And then I pray that my hands are guided to where they need to go, and they are. But if you have all this extra knowledge, and if you have all this extra training and extra skills on how to guide that knowledge, it seems to me you're in a more powerful situation to deliver more thorough and more complete treatment. Now, if that's my summary on what we said the other day. If you want to trigger me on anything else, that's what I remember from our discussion and what I wanted to say about intuition.
Thank you, David. And I just wanted to add that, we are holistic practitioners. Most everyone that is a massage therapist embraces the idea of holism. And the holism of the educational process is important as well. And when we're only focusing on science and not teaching our hands to be compassionate, and we're not teaching ethics, and we're not teaching palpation skills, then we're missing the boat. In the same way, if we're teaching compassion and we're teaching palpation skills, but we're not teaching scientific basics, again, it's not the whole picture either. So embrace your holistic process in education as well as in treating your clientele. And the only other thing that, and it just came to me that I wanted to mention to you, is in teaching the assessments in my second semester of my massage therapy school, I observed the process of how people learned. And learning to use the goniometer was always hardest within the first 2 to 3 weeks. Everybody was clumsy, and had I not been there to say, you have to do this, and it was left up to them, they wouldn't have done it at all because they were frustrated. But after doing it a number of times, it was usually about 3 to 4 times a week for a couple of weeks that we worked on a particular area. After doing it 4 to 8 times, then they understood what it was, and the time frame went from taking 20 minutes to do it to 3 minutes. So I saw that, and this is a self-motivated program, and I just like David, I want to encourage you to find people that you can practice on so that you don't feel embarrassed in front of your clientele. I would not practice on clientele unless I felt really comfortable doing so, because most likely you're going to be looking at your manuals and looking at the pictures of the movements and so forth. So I encourage you to take your time in learning these, and don't try to learn all the body at one time. Just take one segment and then proceed with that. Okay. Well, I think we've covered that topic. The next thing I'd like to go to is to look at some of the forms that Sam downloaded. And Sam, if you is he there? Sam? He stepped away, so
I'm here.
Oh, good.
I'm here.
Oh, great. If you can put up. Okay. If you can put up the client history form, I'm going to begin to talk about that. The client history is in your manual. We don't have a separate page in the handouts that Sam put on the website. However, you certainly can copy these client history forms all you want from your manual. And I thought it would be an important thing to be able to show you one that was filled out, just so you have a sense of what it might look like if you're not using a history form at this point in time. The first information, just the client information, is important, and then we're looking at checking all conditions that the client has experienced within the last 2 years. Mark an X next to current conditions. So you're going to use a check for any conditions that you've experienced within the last 2 years, and an X. So you'll see that some have both. For instance, with osteoporosis, this person has had osteoporosis for the last couple of years and also is dealing with it right now. Same with arthritis. When we came down to accidents and injuries, this is a current problem, as is the neck pain, the numbness and tingling, and the muscle tension. So I think this is important just so that you know what is current and what is kind of a long-standing problem. All right, and then when you're looking at the diagrams, having them shade in tense or painful areas below. And I like to, and this was my addition, where I put active pain is 4/5 in the darkest areas that are written there. So, and then I initialed. Any time the therapist is writing something on a history chart that is being filled out by a client, put it in parentheses and then initial it so that it's clear that the therapist wrote this, not the client. All right, there's a place for other conditions and or information that the person wanted to communicate. Are you currently under the care of an MD, DO, or DC? If so, and for what condition? I really think this is important. There's times when, because of a particular condition, I may feel that I need to communicate with the physician or the chiropractor or the physical therapist even before I proceed. So having this information is good form. Have you taken medicine today? If so, what and for what condition? I've got 3 different medications that the person has taken, and one of the medications that the person is taken, low pressure, as we'll see in a little bit. It's important to know that because there is a treatment modification in regards to working with somebody that's on low pressure. And you might be saying, well, I don't know anything about medicine. How am I supposed to know that? Well, let me just guide you. There is a book for massage therapists on pharmaceuticals and how medications interact with massage therapy. So you can Google that, look on Amazon, and Pharmacology for Massage Therapists. Very excellent book, especially to have in your, your office, just in case you're wondering. And then very important to know what the reason for the massage session is today. And if there's any areas that they don't want you to work. So then we go to the informed consent. I've read lots of different informed consents. This one is just a general one that I've used for many years. And then I like to have in writing that the session will last for a particular amount of time for a particular fee, and then have the client sign it. The reason we do this is that this became an ethical situation some years ago. There was a really good article in one of the journals about massage therapists doing something like they'll work for, if they were going to work for 75 minutes, and then they've already worked for 65 minutes and they haven't even turned the person over yet, and then they'll say to the individual who's on the table, very relaxed, I can do the rest of the massage, but it's going to take me another 30 minutes. I have the time. It would only cost you this much more. What do you think? That was a common practice for a while, and is very unethical. We're dealing with people with their clothing off. We're dealing with people that are exceedingly relaxed and certainly want the whole package, and so some say that this is not the atmosphere to ask someone if they will pay more money for a session. I think you can see that the ethical considerations here. So it's important when you agree upon a time and an amount that you stick to that. Don't change it somewhere, because complaints have been made about that very issue with clients being really upset that they wound up paying so much more, and later when they thought about it were very unhappy. All right, let's look at the next page, Sam, if you would. Now this is page 2 that's in your history, and actually it's not page 2, I think it's actually page 5. But on page 2 there's a good explanation about, or excuse me, it's not page 2, let me find this. It's on page 6, where we're looking at the client history interview. And this may be new to some of you. I'm familiar with this from my nursing background, and I find it most important, I mentioned this before, that we don't just have somebody fill out a history and then you don't look at it. How many times has that happened to you at a doctor's office, that you spent 10 minutes filling out 3 pages of history, and then you notice that the doctor doesn't even look at it and doesn't even know what's on it, and you've poured your heart out. Well, in massage therapy, we take the history form very seriously, and we want even more information. So on page 6 in your manual, there's some things that we might ask. We might ask how long they've had a condition, and if it's been diagnosed, how was it diagnosed, if whom, were there x-rays or CAT scans. Getting that information is important because, you know, a lot of people now self-diagnose online. They just look things up and figure that they have it because, you know, Aunt Betty had it, and so they might have it too because they have the same symptoms. So it's important to understand that because, you know, people can be wrong. All right. Are they receiving treatment now? And if so, for whom and what? And I find this to be very important with chiropractic. There are times when a chiropractor may not want their client to have a massage session. There's times when a chiropractor does not want tissue to relax because they're trying to create some scar tissue in order to bind the spine or do something different. So if somebody is in therapy with a chiropractor and they're coming to you for the same problem, I would feel most comfortable knowing that and communicating with the chiropractor just to make sure that that's all right to do. What are the symptoms, duration, and severity? I've given examples in the manual of, for instance, dealing with varicose veins. Not all varicose veins are the same. Some are very severe. Some varicose veins are so advanced that I probably wouldn't even work in the area if they had varicosities. So getting information is very important. Just knowing they have varicosities isn't enough. And have they had complications? How does this problem affect your overall body, mind, health, energy? So all of these questions are important. So going back up to the top now, with this particular history form that we just looked at, the questions that I asked was about osteoporosis. I asked how long they had it and how long, you know, they'd been diagnosed, and then found out that it was never diagnosed, that the individual just thought they had it because they had a genetic predisposition. All the women in their family had it, so they figured they had it. Not on medication at all, and not having any symptoms of it that they can see. Then I asked about an X-ray or the diagnosis of arthritis. Many people say they have arthritis because their doctors told them that they do, but they've really had no X-rays or blood work or anything that might indicate that they have arthritis. Now this individual did have X-rays, and bone spurs were seen in the neck and the upper thoracic spine. And then I put by the DC, by the chiropractor, was the one who took the X-rays. Then I asked about the treatments that she was getting. The DC is using an activator in neck adjustments and sees her every week. Then questions about the arm numbing and tingling, and this was a concern of the chiropractor. The client had not mentioned it, thinking that it was something to do with her diabetes, but the chiropractor, after working with her, thinks that it's a possible thoracic outlet syndrome from the whiplash that she had, and then referred the client to me. So, and then asking about diagnosis of diabetes and what type of medication they're on. You know, treating a diabetic who's been a diabetic since they were 10 and now they're 60 is very different than somebody that was just diagnosed a year ago and isn't on insulin and is well controlled with oral medication and exercise and diet with no neuropathy. So knowing the process and how severe a condition is makes all the difference in what it is that you're going to do and if there's going to be contraindications with this. This particular person had no neuropathy, and so neuropathy is a contraindication for heat, for cold, maybe even for deep work, but there was none here. And then the individual had an increase in blood pressure for 12 years, knowing what her normal blood pressure is, and then later, you know, looking at the medications. Then writing down indications for massage therapy. Now, we did this in our school. This was a school routine here, and the reason that I did this This was not my idea. This came from the Commission on Massage Therapy Accreditation Standards for Education. They believe that if a massage therapist has to write down what the indications are and what the contraindications are, that they won't forget it. And you know, you might say, are you accusing me of being scatterbrained? And I'm going to say, no, what I'm saying is, okay, sometimes I'm scatterbrained. But the reason why has to do with our relationship with our client, and especially when we're dealing with people that are in pain. And if you're empathic at all, it's very easy for you to get into a session and to let your hands guide you, and you're massaging and you're feeling, and you know, they're liking the work, and then all of a sudden you're so focused on something that you forgot what your initial indication was, and you also forgot a contraindication, and maybe you massaged legs too deeply even though you knew that they had had a blood clot 2 years ago. But if you write it down, this kind of sinks it into your consciousness much better than if you just think about it briefly and you don't put it on paper. So that's why CompTIA required that schools that were going for this type of accreditation have this type of education. So if you are not doing this, writing down indications and contraindications for massage therapy is very helpful, and it also covers, it's that CYA thing, right? It covers you, showing that you knew it and that you were modifying it. So just writing down here the modification for low pressor. Low pressor is a beta blocker, which means that it suppresses the sympathetic nervous system. This means, in relation to massage therapy, that people that are on these types of beta blocker medications, they can get too relaxed in a massage therapy session, and often when they stand up, they'll have a blood pressure drop. Some people faint. Some people even get nauseated because the body is not able to come back from the relaxation in response to the low pressor, which is, like I say, suppressing the sympathetic system. So the parasympathetic system is dominant, even more so after a massage, and this makes the vagus nerve react, and you know, heart rate can go down, they can faint, get nauseated. So that's the therapy modification, is to stimulate the nervous system after the session, and then stay with the client when they're getting up just to make sure that they're not faint. All right, the last part of this has to do with the treatment plan. And there we go, thank you. The treatment plan, I just wrote down the assessments that I was going to do, and then what I wanted to treat, and what my initial plan was, and then doing some passive range of motion with muscle energy technique, and stretching as tolerated. And then I also wrote a note that I wanted to have the client sign the release of information form for the DC report, and I didn't want to forget that. So one other thing, Sam, if you could go up a little bit to the top, I just wanted to show, remember how I was talking about marking out the lines? In the interview notes, I closed up the lines with these diagonal lines to indicate that I was done. Farther down, however, you'll see that under indications for massage therapy, that should have been done to the right of the words and all the way down. So when you're done with your notes, you want to be able to mark through the lines that are vacant, and this is just standard documentation procedure. Okay, David, that was a mouthful. Are you still awake?
Yes.
Do you have any comments?
No, it's great.
Okay, all right, very good. All right, let's go on. And I'm not sure, Sam, how are we doing with time? Have we been talking an hour, and should we leave this for another time?
For a while, but I think it's such good material. I don't see any reason to stop, Juanita.
Okay, all right. What I'd like to do then is to go on to the SOAP note that I wrote in relation to Jane Doe, and we'll briefly kind of look at that SOAP note. And again, you have these blank pages in the forms that you can download from the website. All right, so SOAP notes, SOAP. How did that come about? When I was in nursing, for the first 7 years that I was a nurse, we had to document all the time, but we did not use the SOAP format. That came in later. It was just a basis of structure so that all professions were on the same page. Basically, before we had the SOAP notes, we knew that in our notes we had to put down what the client told us about their condition. We had to put down what we were observing as the nurse or the therapist. We also had to put down any type of therapy that was given and how the client reacted to it, and then a plan for future therapy or future care if the person was in the hospital. So that's what the SOAP stands for. The S is subjective, and here we've got, I'll just read through it if you're not familiar with the abbreviations. Complaints of headache, arm numbing and tingling, right side pain is sporadic, right neck stiff, pain with movement is active today, 3/5 on neck lateral flexion, lateral rotation, and extension. All right, so that's information from the client. Now, certainly she didn't come in and say, I have, pain on lateral flexion, left rotation, and extension, but I can put that down there because as I'm doing, as she's doing the active range of motion and I'm asking her about whether the movements are painful, then she tells me that. So even though this might be in my words, the information is coming from her. And that's considered objective and measurable. Then the O stands for objective, and that is information that the massage therapist observes. So in this situation, I was not using one of the neck assessment sheets, so I was just writing information down. Neck compression test is negative, Adson maneuver is positive, C, active range of motion below, pain upon palpation, which is pain. That's not active pain. Active pain is when a person comes in and they have a headache. That's active pain. Pain upon palpation is when the person, you're doing massage and all of a sudden they say, oh, that's sore. I didn't know that was sore. That's pain upon palpation. All right. And so then I also charted tender points and trigger points. We'll see below. The HT is hypertonicity noted, and then see the STTs below. A is, I learned that A stands for action. Some people learn that it stands for assessment. I think action is a better word because assessment sort of gets confused with objective. So action, right. So action is heat on neck and right shoulder. See modalities below, active range of motion increase, 15 degrees with lateral flexion, 20 degrees with lateral rotation or left rotation. Responds with decreased pain, 3/5 changed to 1/5. A headache gone, a taut, active range of motion of neck and shoulder. So that's what I did and how it worked. And then the P stands for plan. Continued massage twice a week times 2 weeks. Heat with neck and arm, active range of motion twice daily. BID stands for twice daily. Sleep with scarf around neck, magnesium lotion to neck at bedtime. And so those are some self-care information, as well as the information about when they need to come back in for massage. So David, I see that my voice is putting you out. Do you have any comments?
No, it's great.
Okay, all right. All right, so let's go down a little bit farther, and then we'll see some of the concise work. Sam, if you can make that SOAP note come down. All right, so I've got the different kinds of modalities that I do, and I just checked what I did. And I wrote in that I did it to the neck and the arms, and made some notes along the way. And then with the the diagrams, I wrote down the STTs, which were measuring the HT, and showed at the bottom of that there was no change after the session. And then I was locating a scalene trigger point, an SEM trigger point, suboccipital trigger point, and trap trigger point, and measuring the hypertonicity in the paraspinals with tender points in the lamina groove, and so forth. And then I wrote down the measurements of the neck active range of motion, and also wrote in that there was a forward head posture of 1 inch, and internal shoulder rotation was bilateral. So those were my notes for the session. If we're using the extra sheet, we can, put even more information on that. All right, the last little bit that I want to cover, and this is also from your manual, and I'm not going to read through all of this, but I wanted to give you the completed SOAP notes on page 24. So Sam, if you can put those up. When I taught this in a live class, I would always go through the SOAP notes and have everyone correct what the SOAP notes were supposed to look like, because I do not have these, I don't have the possibility of having a capital P with a circle around it, and yet that's what we use for pain. So what I've done here is that I've put circles around things that required circles. I've put little lines over the S, the P, the A. I put a circle around bilateral, around massage, around left, around right, and you can kind of look at these in relation to the notes, just so that you remember that these are the abbreviations for such. All right, and then the next page has the abbreviations that I've used in these SOAP notes. When I was teaching SOAP note charting, it was quite a process. We always taught it in the classroom. Every time students worked on each other, they had to take intake forms and do SOAP notes, and then they would be corrected by the instructors. Same thing for the student clinic, so that every time they worked on somebody, we had to check their notes. So it was a process, and our course was 10 months long, and by the time they completed school, they were, they knew their charting back and forth. One thing that I learned for sure is that using abbreviations and using charts and diagrams can make things go much quicker, but using too many abbreviations can get really complicated. So I tried to keep it at the bare minimum of abbreviations, and these are the ones that I've got. Again, I put circles around the right or the left. I put a line above the S, a circle around M, and so forth and so on. You can kind of see what I did there. And then I also added the word hypertonicity at the end, and you can add that with capital HT, meaning hypertonicity. Okay, that's enough. This is all such detailed work, and it's not wonderful and juicy to talk about, but I hope it can help you all in your process of making changes if you're not currently documenting well. I know that there's online programs. Some people have invested $400 or $500 in an online program for documentation, but most people have not done that and rely just on their, their own handwriting and their own paper charts. So one other thing that I did not mention about our documentation is we should always keep our clients' charts in locked file cabinets when we're not there, and just be mindful of other massage therapists that might have access to your files. They really should be kept under lock and key. Okay, I'm all done with this, David, and is there anything else that you wanted to add to this?
Yes,
today?
I want to thank you for going over all of that material, which may seem laborious, and yet in reality, it's what makes us more capable of doing clinical work if we can record it, because as we said before, if it's not recorded, it didn't happen. If you end up in court, if you end up being called in by a physician or wanting to have referrals from a physician, they will notice what you're doing in your reporting.
Right.
And if you're accurate, and if you're concise, and if you're appropriate, then it adds credibility to your overall clinical approach.
It
So it
does.
warrants the time that we take to do this. It warrants the time that you take to thoroughly go over what Juanita has discussed and to go over that chapter, that manual in number MMT6, and to use this whole procedure. It is very valuable, and it will enhance your clinical credibility and your practice.
And folks, if you have any questions or comments, please put them on the chat, and we'll see you again another time.
I did want to, before we sign off, I did want to offer the wonderful notion of a photo of their active range of motion,
Right.
using their own cell phone cameras, because
Right.
then you can get a record, an ongoing record of their progress with your work, and you don't have to be responsible for warehousing those photos.
Exactly.
They
That's
can
wonderful.
go back to their own phone, and they can see the progression of your work.
That's
and
right.
that's a very, very valuable process, and it's a very simple thing. You don't have to get involved with storing those records.
Very true. Very true.
And that's
Well,
a great suggestion, Sam. That's a great suggestion that makes just way too much sense, because in fact, a picture's worth at least 1,000 words sometimes, and a picture of that range of motion that shows a side-by-side after Juanita's treated the neck or the ankle or whatever it is, side-by-side photos of what has happened after 1 or 2 or 3 sessions is very dramatic, and people would love to show that to folks and say, look what happened, here's the difference. So it becomes a credibility information, credibility, and as well as a marketing tool. So there
It actually becomes a referral tool. Sure, a referral tool that can show their friends the good work that you did,
exactly.
and send them to you.
For sure.
Makes real good
For
sense.
sure.
Thank you for adding that.
All right.
And thank everybody for attending. We're so glad that you were here, and we're so glad that you're in this program, and we're glad that you are. We appreciate your dedication and your interest in this whole process. Thank you.
Bye. My dogs are.
Thank you, Juanita. Thanks for your dogs for being quiet today.
I know,
and
they were so
thank
quiet.
you all for your patience with us. We're sorry that we got off to a rough start, but this turned out to be an excellent program, and we're thrilled that you're able to benefit from this information. The test for MMT6 will be posted this afternoon, as well as the course evaluation for MMT6. And that will round out this program for many of you. So stay tuned. We'll be working, as you finish these tests, we'll be working up your certificates and sending those out to you. And if you are able to attend one of the 4-day workshops that are yet to occur, we've got, where are you going, David? We've got Baltimore coming up.
Yes,
and Fort Wayne, Indiana. And,
I'll be in Baltimore May 13th through 16. I'll be in Fort Wayne, Indiana from May 20 to 23. And I did want to say that I have, for both of you, neither of you have seen the rather glowing evaluations that I received from students in the 4-day class.
Great.
They were quite interested and quite ecstatic that they could add this 4-day live experience onto the lectures and onto the videos and everything they've done online. So they found it to be a very real experience in every way possible. So thanks for attending, everyone, and I look forward to more of you attending the 4 days. Thanks.
Bye, all.
Bye, all. Thank you again.